Hi, this segment is about the lap band, a bit about how it's built, how it's placed, how it's supposed to work, and how it turns out not to work very well in the long run. This is a model of the lap band. This segment here represents the band itself as it's wrapped around the upper part of the stomach. And the idea is that the band, which is like a flexible belt, has a balloon on the inside lining, and this balloon attaches to this tubing. This port is placed underneath the patient's skin, and the neat thing is that the surgeon can adjust the tightness of the band over time by putting fluid into this port or perhaps taking fluid out of the port. So the balloon, which fills or empties, will squeeze on the stomach to a calibrated degree, and what it's supposed to do is give the patient a controlled sense of satisfaction or satiety. The lap band was approved for use in the United States by the FDA in 2001. There is a lot of enthusiasm for the lap band initially because it's fairly easy to place, recovery is quick, and initial results are very favorable. Patient acceptance of the lap band is very good, the sense of control is excellent. The problem comes about 2 years or 3 years or 5 years after the band is placed, when the sense of restriction begins to fade and the sense of hunger begins to return. What happens over time is that the band, which is simply constricting the stomach, begins to cause a sensation of blockage in many patients that feels uncomfortable, and the patient has a sensation of working against their band instead of the band helping them. An important thing that research has shown us about obesity over the last several years is that the obesity problem actually comes from an imbalance in the internal hormones. So if a weight loss intervention is going to have lasting and sustainable effect, it's going to have a positive impact on that hormone balance. And that's a problem for the band. The band works mainly by restricting the amount of food that a person can physically hold. It doesn't actually affect the appetite or the abnormal hunger mechanism. So as surgeons gained experience with the band, they identified another problem with the band, and that is the fact that the band leaves permanent changes on the upper stomach where it's placed. The band was once considered to be kind of a surgical freebie, and the idea was that you could take the band off without leaving any permanent change on the stomach. That unfortunately turns out not to be true. It turns out that the band leaves some scar behind on the stomach where it's placed, and it also puts a certain degree of strain on the esophagus, which is the swallowing tube, and some patients who have a band have esophageal damage or failure that lasts for many, many years. I was among many surgeons across the country who got on board with the lap band when it became available in the early 2000s. This looked to us like a good addition to our surgical armamentarium, having a band as a less invasive option and other procedures like the gastric bypass or the sleeve as bigger or more invasive options. However, as I saw the results of the band over years in my own practice and my own patients, I became a bit disappointed, and in the 2008-2010 time frame, I gradually eliminated it from the list of surgical options for my own patients. So if we no longer talk very much about the band as a surgical option for our patients, what do we offer to those who suffer from obesity? Well, we have several major surgical interventions such as the gastric bypass and the gastric sleeve, and an operation that's gaining popularity these days is the duodenal switch. We also